Yeah. Doctor, is this your whiteboard? Doctor? Doctor, is this your whiteboard?
No, no, it's not. No, it's not my whiteboard.
Okay,
no.
Sorry. Yeah. Dr. Pierre, yes, we are starting the session. 2 minutes. Yeah. Good evening to each and everyone over here. I am thrilled to welcome you all for the today's informative session. I am Vijay, manager from Mediversal Academy, and I have the privilege of introducing you our esteemed speaker, Navonil Dutt. Dr. Navonil Dutt has done MBBS, fellowship in cardiology, DNB in pulmonology, and working since 2020. Served in the front line critical care during COVID pandemic, teaching and moderating and conducting seminars since 2022. Part of the West Bengal Rheumatology Association and a very regular to their CMEs and seminars organized across the country. During MBBS, doctor was a part of SAMSA, which is South Asian Medical Student Association from 2017 to 21. In the year 2019, he was awarded with the best poster case presentation at the International Undergraduate Conference, that is Consciences 2019 in JIPMER Puducherry. Over to you, doctor.
Thank you so much. A very warm welcome and a very good evening to all the participants here. It's an honor conducting a webinar for Mediversal every time, and I was really thrilled with the audience and its response the last time that we conducted a webinar on chest pain and approach to different cases of chest pain. And what I've tried this time is to create a similar environment, although the topic is something which I have tried to make it as concise as possible so that it does not extend beyond a certain amount of time as well. And at the same point of time, it can cater to all the areas that we want to discuss. I warmly welcome all of you, and I hope that you have had a very good festive season. So happy Dashera to all of you. And to all of you who are in different parts of the world, I hope you're doing well and hale and hearty. So yes, I'm going to start off with the session very soon. But before that, I would want to know if what is exactly the current stage of preparation that you're in. Are you all in your MBBS days? In which year are you in? Or have you passed out your MBBS and you're doing your fellowships or you're pursuing your post graduations? So if someone could drop me a text, if you could just drop me a text, I just want to know like what exactly which state of audience I'm actually catering to, so that will actually help me mold my discussion accordingly. Yes, Dr. Twinkle, good evening. Dr. Anu says MD residency. That's great. What about the others? If you're in your MBBS, you can write which year of your MBBS you are in. If you are pursuing your residency, you can write to me which completed MBBS now working, medical officers, BAMs, internship year. That's lovely. That's lovely. MBBS, MDDM, cardio, seniors in service PG, recent MBBS pass out. Okay, thank you. Thank you so much. Thank you. So the reason I always ask this is because there's always a mixed cohort of audience that we have. And I deliberately try to keep my presentations in a way so that it can cater to all the cohorts, and it is something which everyone enjoys during the procedure. So for someone who has done a DM might find it a little underwhelming, but I guess you'll understand that this has been done to keep the niches of every cohort happy, satisfied, and interested. And I hope that no one feels like an outlier here. So that is the whole concept of the entire thing. Yes, I can be a bit loud. Is my audio a bit diminished today? I am not having a good throat.
Okay.
I'm not doing really well, particularly, but I would try to
Sorry,
Try to
doctor. You
be
can
like,
continue. You can continue.
yeah. Is everything good now? Is everything good now? Vijay
Perfect,
sir, is
perfect.
everything good?
Perfect, doctor. Perfect.
Perfect. Okay. Thank you. So I'll be sharing my screen, and we can then embark on this journey together. And I hope you'll have a good time. So can you all view my screen? Can everyone confirm if my screen is visible?
Yes, it is visible.
Okay. Yeah. So I will be beginning this session, and let me just connect this from my phone as well so that I can keep a track of your chats and your comments at the same point of time. My internet is a little unstable today, so if there is any place where you feel that my voice is somehow broken or something, you can always let me know, and I'll always try to repeat that part. So I'll be joining from my device as well, and yes. So uh, our topic today is the guardian angels in diabetes mellitus, which includes insulin therapy, OHAs, and goal of management. Uh, what I've tried to do here is I have talked about, in a nutshell, the different pharmacotherapies that we can do in diabetes, the different pharmacotherapies that we have been seeing since the last, you know, 80 to 100 years in diabetes mellitus. And in fact, let's be honest, the real OG, as we call in the Gen Z language, the real OG disease that was, treated in modern medicine, which makes it completely a benchmark success from what it used to be back in the early days of Ayurveda or local medicine or or holistic social medicine, is actually the development of insulin. And it is with due respect to the inventors Banting and Best that insulin came up. And without insulin, probably the world would have been a completely different place, and no doubt why they were awarded with the Nobel Prize a few years later. Because once upon a time, diabetes was thought to be a disease that was created by God, a disease that was a wrath of nature, and a disease that barely had any kind of cure. And from it was something that affected all age groups unanimously. And the worst part is we did not know how to treat. There were several opinions about what we can do, about what drugs we can choose, but no one really came up with something solid, something which was substantial enough to say that this particular therapy can reduce the mortality, can reduce the hospitalization, and definitely prolong the quality of life. So that is exactly when the world sees the invention of insulin, and the rest, as they say, is history basically. So that's exactly where I'll start from. And as always, when I begin, I always try to you know share my gratitude to the ones who have taught me. So thank you to the maestros from whom I have learned medicine. Dr. Dilip Kumar happens to be uh, uh, an, an an internal medicine specialist from the Mehta hospitals, the Mehta super specialty hospitals, Chennai. And the one next to him is DOG, Dr. Zainab Vora, who happens to be a radiologist from AIMS, and someone who has not just been a mentor, not just been a teacher, but someone who has actually taught me how to study and taught me how to view an integrated form of all the subjects together. So thanks to both of them. And that's exactly where we'll begin our session today. So before I go into the very depths of pharmacotherapy, I'd once love to talk about the very basics of what diabetes is, of what our standard protocols are when we want to diagnose diabetes mellitus. So when we talk of a normal fasting plasma glucose, it's anything less than 100 milligrams per deciliter. Of course, it can vary from lab to lab, and it can vary from the the instruments that are being used. Anything which is less than 140 for a 2-hour postprandial glucose, and any HbA1c less than 5.7 is considered to be normal. And anything above or equal to 126 milligrams per dl for a fasting, anything above 200 milligrams per dl for a 2-hour postprandial glucose, and anything more than equal to 6.5 for an HbA1c is what we usually call as diabetes mellitus. Although most patients who do present to us in the emergency or the OPD may not be always in a fasting state. So we clearly say this, that any random blood sugar of more than equal to 200 milligrams per deciliter with classical clinical features. When I say clinical features, I particularly mean polyuria and polyphagia and polydipsia. These are the predominant clinical features. So polyuria, polyphagia, and polydipsia. Although the recent guidelines do say that polydipsia is not a major clinical feature that we may get in diabetes because it's a very non-specific finding. So majorly, these are the criteria by which we can diagnose diabetes mellitus. And anything which lies in between the values, that is a value of 100 to 125 milligram per deciliter for a plasma fasting glucose, or a value of between 140 to 199 plasma, 199 milligrams per deciliter for 2-hour postprandial glucose, and an HbA1c of 5.7 to 6.4 is something which we call as a pre-diabetic state. So that is something which we are very clear about, and it's something which is very basic. And we have certain forms of diabetes, which is type 1, type 2, MODY, and LADA, which I'll be going to later. But something that I want to really stress on, and something which is indeed the need of the hour, something which has been spreading like a wildfire on an epidemic these days, is something what is called as the metabolic syndrome. So in metabolic syndrome, we are having certain parameters like obesity, like dyslipidemia, where we are checking for triglyceride levels and HDL levels. We are checking for hyperglycemia and hypertension. So according to the guidelines, the current guidelines that we have, any obesity where we say waist hip circumference of more than 102 centimeters in a man, or more than 88 centimeters in a woman. Although this is predominantly via the US standards, and India does not per se has its own set of guidelines which will guide us to what the waist hip circumference should be in case of Indian population. So, but we still consider that we still consider the US standards, and via the US standards we can clearly say that it is anything more than 102 centimeters for a man and 88 centimeters for a woman that we consider as obesity. Please note that this is waist circumference and this is not hip circumference. This is a common mistake that people tend to do. It's waist circumference. And when I talk of dyslipidemia, as I said, predominantly we are going to mean the triglyceride levels and the HDL levels. And when I say triglycerides, any triglyceride of more than 150 milligram per dl, or a patient who has been treated earlier for an elevated triglyceride or is under treatment for dyslipidemia. Any HDL that is, where a male is having an HDL less than 40 milligrams per dl, or a female having an HDL less than 50 to 55 milligrams per dl, is what we would classically use in the criteria for HDL. And when I talk of hyperglycemia, any fasting plasma glucose that is more than 100, that is anyone who is pre-diabetic or diabetic, doesn't matter, or someone who is a known diabetic and is being treated for hyperglycemia. When I talk of hypertension, the blood pressure values are 130 millimeter mercury in systole and 85 millimeters of mercury in diastole. So anything which is more than equal to 130 by 85 is something which we would consider. So someone who meets 3 out of the 5 criterias is predominantly said to be suffering from metabolic syndrome. And if all the criterias are met, then it is a definitive diagnosis that we can do. And why is something called a metabolic syndrome gaining the attention? Why is it becoming a wildfire or an epidemic? It is because of the complications that it can create. It can lead to complications like gout. It can lead to complications like type 2 diabetes mellitus. As I said, it is something, it's a very small window for a pre-diabetic patient to become into a diabetic patient. And metabolic syndrome is the real driver of all of this. It does increase the cardiovascular risk. It does increase the risk of things called obstructive sleep apnea, because These are the cases where you start gaining abnormal amount of fat in the neck, and your neck circumference rises beyond a certain acceptable level. And it can also lead to something which has been coming up very much in the last 2 or 3 decades. That is the emergence of a disease which is called non-alcoholic fatty liver disease, which can later progress to as bad as non-alcoholic steatohepatitis, or something as bad as non-alcoholic cirrhosis. And in something which is in females is extremely common these days. I think 7 or 8 out of every 10 females that I meet has been suffering from this, and we all know this, that it is something which is called a PCOD. It's not PCOS, because the polycystic ovarian syndrome consists of a lot of other criteria, but polycystic ovarian disease is a spectrum which does come under metabolic syndrome. And one of the classical cases where we find that these patients who initially have been diagnosed with oligomenorrhea or amenorrhea, for example, and their ultrasound is showing bulky ovaries with multiple cysts in it. Later in time, they're progressing to a certain point where they have been shown to develop diabetes mellitus or become pre-diabetic, and later when they conceive and when they become fertile, and when they are in their second or third trimester of their pregnancy, we find them gradually developing something which is called a gestational diabetes mellitus. So that is something which we really need to understand, that metabolic syndrome is something which is a potent driver of the other complications that we mentioned here. And we can clearly see this is the skin manifestation. I'll just create a slideshow so that this becomes easier. So this is a skin manifestation that you can see. The skin manifestation is typically what we call as the, can anyone name me what the skin manifestation is called? Anyone in this chat? Anyone in this chat who can name me? Yes. Yes, I'm getting already a few answers. This is Dr. Talviz, if I'm not wrong in mentioning your name, Dr. Bhumika, Dr. Farhana, Dr. Bhagyesh. Yes, all of you are perfectly correct. This is acanthosis nigricans, where you find a dark or a hyperpigmented patch around your neck. It can be found in your axilla, it can be found in your groins. And this is a typical dermatological manifestation of metabolic syndrome. There are so many times that people confuse this as a manifestation of diabetes. It is not just a manifestation of diabetes, it is a potent manifestation of metabolic syndrome. So for all the ones who are young right now, I'll always say this, keep your waist circumference in check, keep your neck circumference in check. We always say this, any neck circumference which is more than 45 centimeters is a very, very potent risk factor for something which is called obstructive sleep apnea. For the ones who snore out loud despite not being tired, I mean, snoring when you are very tired on one fine day, 1 or 2 odd days, is perfectly okay. But if you have a persistent snoring with BMI on the higher side, then you need to be careful. You need to take care of your parameters. Please do get a thorough checkup of the parameters which are checked in metabolic syndrome, and especially for women who are in the fertile phase, reproductive age women between 15 to 49 years. This is one thing which is one of the most common causes of infertility in women, that is PCOD, polycystic ovarian disease. So having said that, we would now walk into, okay, there's a question which I found a while back. I missed this from Dr. Nazia. Is this as per idea for ADA? It is as per the ADA guidelines, my dear. It's as per the ADA guidelines. Okay, so now we look at the different forms of diabetes, but I just ask a very common question in this group. We all know about type 1, we all know about type 2, we know about MODY, and we know about LADA. Do you know what is type 3 diabetes? Anyone who can tell me what is type 3 diabetes? I'm able to follow your chats, so please don't Google, please don't use ChatGPT. You're free to make mistakes. We all make mistakes, and I'd be glad to discuss with you. So anyone who knows what is type 3 diabetes? Somebody saying GDM is, do you mean gestational diabetes mellitus? Dr. Dill, Dr. Anu, is that what you mean? Okay, I finally have a good answer. That's Dr. Nazia saying insulin resistance leading to Alzheimer's. Perfect. Yes, Dr. Balaji, Alzheimer's. Yes. Yes, yes. No, it is not juvenile DM, my dear. It's not juvenile DM, Dr. Pradyumanshish. if that's your name, Pradyumna Shish. It is indeed insulin resistance that has been found to be affecting the brain cells, to be affecting the neurons, to be leading to exaggerated or enhanced neuronal apoptosis. That is indeed a major driver of Alzheimer's. So basically, it's being said that Alzheimer's, which was earlier considered to be a disease of the elderly people, but now it is said that excessive stress, excessive emotional stress, physical stress that can lead to high cortisol levels. And at the same point of time, if this patient is having insulin resistance, it can predispose to a condition where the, the neuronal debris start accumulating. There's an exaggerated apoptosis of the neurons in the brain, and that can lead to early onset dementia, which is around the age of 40 to 50 years. So, in fact, increased screen time is also something which has been linked to excessive neuronal apoptosis. Did anyone know this? Increased screen time. Can you tell me what increased screen time can lead to in a child? A child who is using excessive screen, mobile tabs. Although it's a little out of topic, I just want, because I'm bringing in screen time, I just want to ask this to you. Anyone who's aware of what excessive screen time can do in a child? Anyone? Yes, I'm getting good answers. I'm so glad. I'm so glad when I get such good audiences, and especially on a day when I'm not particularly doing well. It's you who keep me going. So yes, ADHD, particularly ADHD. Yes, we do find other developmental delays as well, but ADHD is something which is so common. And there's been so many kids whom I find the parents are ranting that my kid does not listen to me. My kid always throws tantrums, and he's running around the house and all of that. But then when I go into a deeper history, what they have to say is excessive screen time. So I ask them, who has given them the phone? Who's given them the tablet? I mean, how does a 3-year-old need an iPhone? How does a 3-year-old need an iPad? Need a MacBook? So it's them who are giving it. So yes, impaired language and social skills. Perfect, perfect. So ADHD predominantly is something which has been linked to an increased screen time. Okay, so thank you. So now, as we come back to the different types of diabetes, we predominantly, when we were studying diabetes, even 2 to 2.5 decades back, we had something called a type 1 diabetes, which was in short called the insulin dependent diabetes mellitus, and in type 2, which we earlier used to call as the non-insulin dependent diabetes mellitus. But trust me, these languages and these terms of insulin dependent and non-insulin dependent have almost become obsolete now, because even a type 2 diabetes mellitus patient who is not responding to OHAs and oral hypoglycemic agents may need something that may need insulin therapy. And there are so many times that uh, insulin has been a lifesaver for someone who has been a type 2 diabetes mellitus, uncontrolled type 2 diabetes mellitus, and not responding to oral drugs. So yes, a large part of the late 90s and the early 2000s was just about type 1 and type 2, until we discovered the two other types, that is MODY, which is also known as maturity onset diabetes of the young, and LADA. LADA is what we call as the latent autoimmune diabetes in the adult. That is what we predominantly called. So this is a very short table, a very crisp table. I'm sorry if I'm coughing a bit, so forgive me for that. So LADA is something which is, again, as I said, it's latent autoimmune diabetes of the adult. And in a short table, I've tried to be crisp and concise about all the features that we have, and so that the entire chart is something which is very clear to us. So when we talk of type 1 diabetes, what we always used to associate it is with something called autoimmunity and autoantibodies. Predominantly, it's the can yes, I will explain about LADA, Dr. Mayur. I will surely explain about LADA. Can anyone tell me, when I talk of type 1 diabetes, we talk of autoimmune? Can you tell me the autoantibodies that are implicated in a type 1 diabetes? Anyone? I have many residents here as well. I'd be loving to get answers from you as well, dear. In fact, somebody is a DM cardio here, so sir or ma'am, you're technically senior to me. So I'd be absolutely loving to have your answers. Okay, GAD 60, GAD 65 as well. Yes. Anything else? Anything else? Indeed, GAD is one of the most common antibodies that we get. Very good. Very good. Someone who knows the full form of GAD? What is anti-GAD? Because there are so many kids who are not aware of this word, GAD. Anyone? What is IEA? It's islet associated amyloid protein. Yes, somebody says ILA2. Very good, very good. I didn't expect ILA2. Someone who knows what is GAD? Yes, it is glutamic acid decarboxylase. Yes, it is glutamic acid decarboxylase. So basically, when I talk of type 1 diabetes being an autoimmune type, we have certain sets of antibodies, very rightly mentioned by all of you, Dr. Aftab, Dr. Twinkle, and everyone. We have the anti-GAD60, GAD65 antibodies, islet cell antibodies. Mainly type 1 diabetes is one where, we are going to have a very high association of this. And unlike what many people think that type 1 diabetes has a rich family history, no, type 1 diabetes does not have a very rich family history. The age of presentation is somewhere between, the juvenile phase, anywhere between 18 to 35 is what we usually may encounter. Although I have seen that type 1 diabetes mellitus cases even as low as 13 or 14 years of age. So what happens usually in these patients is there is a uniform beta cell destruction. We know that beta cells are the ones which are there in the pancreas to produce insulin, and it is this beta cell destruction due to these autoantibodies that results in absolute insulin deficiency. So remember, it's an absolute insulin deficiency. Unlike type 2 diabetes mellitus, where there is insulin resistance, in type 1, we are going to have an absolute insulin deficiency. And that is why the insulin to glucagon ratio will be lower, because glucagon is going to be high compared to insulin. And all of this is because a beta cell destruction, a global beta cell destruction, which is happening due to the autoantibodies. And that is why these patients have very high tendency of landing in medical emergencies. They have a very high tendency of presenting as life-threatening emergencies in the form of diabetic ketoacidosis. And these patients, as I say, will always need insulin. They will not be responding to oral hypoglycemic drugs. They'll always be needing insulin. And that is exactly where insulin dependent diabetes mellitus actually comes in. So the word IDDM actually is not wrong, but it is only applicable for type 1. But type 2 being an IDDM is something which is obsolete, because there are so many type 2 patients who in the long run might need insulin therapy. So I hope type 1 diabetes is clear to everyone. Yes, yes, very common, will come in ICU with decay. Indeed, Dr. Twinkle. In fact, what is something that we say, if you do not know, this is something which was taught to me by my professor, and it's something that I'll be, reiterating. Suppose a patient whom you have never seen earlier, presents to you in the emergency with a fasting, with a blood sugar of say 400, 450, with urine ketone positive, with a breath which is typically an acetone smelling breath, and you diagnose this patient as DK. This is type 1 diabetes unless proved otherwise. It is very rare that a type 2 diabetic patient will present to you with DK. Mainly type 2 diabetes patients will come. If at all they come, they will come to you in the OPD. But if at all they have to come in the emergency, they'll come with something which is called, anyone who knows what is the acute emergency of type 2 diabetes called? Type 2 developing decay is very rare. What is the medical emergency that a type 2 patient will develop? Yes, yes, perfect. Any more answers? Dr. Dil, is that your name? Dr. Dil, is that your name? DIL? Okay, you've got a nice name. Yes, it is HHS. It is hyperosmolar hyperglycemic syndrome, and that can lead to coma. And in fact, it is said that HHS is worse than decay, because of the osmotic effects that it leads inside the brain, leading to cerebral edema and all of that. But that's a separate discussion. We are not here to talk about the medical emergencies in diabetes. But what I wanted to tell you is, if you have never seen a patient before, suppose XYZ patient is coming to you for the first time, and he is presenting with a sugar as high as 450 with urine ketones positive, just close your eyes and know that this is a type 1 diabetic. Another thing which I'll be telling you, this is a case which, honk is another name for that. Yeah, or hyperosmolar non-ketotic coma. Perfect, perfect. So another case which I'll be sharing with you, something which I encountered during my internship. And why I say this is because back in our internship days, I've worked in a peripheral hospital. It's a government hospital, and you can only imagine the amount of caseload that was there. Every admission day we used to have around 180 to 200 admissions, and I cannot tell you how extensively we had to work in seeing every patient. So I still remember this patient who was referred to us from surgery. I mean, to be honest, one of my friends had mistakenly referred this patient to surgery. It's actually a medicine case. What happened is this patient is a 60, 65-year-old man, and he's not really aware of his diabetic status. And people in the rural setups, they're not always ready to go for screening tests of diabetes. So this man comes with a acute pain abdomen, and my friend who was an intern, for some reason, maybe due to the workload or something, felt that okay, pain abdomen is mainly a surgical case, so he sends this patient back to surgery. And it's then when the surgery people, write a referral letter back to medicine. And this is exactly when I'm seeing this case. And when I see this patient looks dehydrated like anything. The tongue is parched, the mucous membranes are absolutely dry. And when I do a finger prick for a capillary blood glucose, it is around 565. That's the value that I remember. It's around 565 or 600 was the value. And this patient is absolutely drowsy. This patient is having a typical acetone breath. And when we do his urine ketones, we find it positive. So what I want to tell you is, anytime you are in, because I found there are many people who are medical officers. So any undiagnosed abdominal pain in an elderly person, any undiagnosed abdominal pain who does not give you a proper history of diabetes, who is not aware of his diabetes status, any abdominal pain, please do evaluate whether this is a case of DKA which is coming to you, because most of the times, because this patient is going to be dehydrated, it's going to be really, really difficult to get a verbal history from this patient. So the most important thing that you can do is, you can keep this differential in mind, that acute abdominal pain, apart from all the other surgical causes and the medical causes that you think of, you should definitely be thinking of diabetic ketoacidosis, because it's one very common presentation. And if you miss this, you'll basically be losing this patient, because this patient needs urgent, rehydration with fluids. And almost we say that 6 to 9 liters of fluid should be infused in this patient, 6 to 9 liters in the next 24 hours. And of course, this patient needs regular insulin infusion. So that is exactly how type 1 and DK is dangerous. So when we come to type 2, this is very much in contrast to type 1, which was autoimmune mediated. Type 2 is mainly an insulin resistance. So what happens is basically a situation where initially there's no autoantibodies. I mean, there's never an autoantibody. In fact, the beta cell mass is usually preserved. But what happens is the body's needs for insulin are higher than the amount that is being synthesized. Whenever there's a demand to synthesis mismatch, what happens is the pancreas gets a signal, the beta cells get a signal, which keep on telling it that you need to produce more insulin, you need to produce more insulin. But we know that the beta cell mass in our body is usually constant. So if the demand and the supply mismatch is occurring, what usually tends to happen is the the beta cells get overwhelmed, and they start their function starts reducing, because it's like you have 20 workers to make 100 cars. Suddenly there's a delivery order which wants 300 cars with the same 20 workers. Do you think that the efficiency of the workers will be the same? They won't, right? The efficiency will reduce. So it is just a situation where 20 people were making 200 cars, and now, because of the increased demand of the body, and why there's an increased demand of the body, it is because of this insulin resistance. So insulin, that we know, is taken up into the muscles and the fat via a certain receptor. Can any one of you tell me what is the receptor which uptakes insulin into the fat tissues, into the adipocytes and the muscles? Anyone? What is the receptor through which insulin is uptaken into the muscles and the fat tissues? Perfect, perfect. I'm getting so good answers. I'm getting so good answers. Good. It's GLUT4. So GLUT4 is what is helping in the uptake of insulin into the insulin sensitive cells, like the adipocytes, like the muscles. And can anyone tell me, what is the GLUT channel through which oral glucose enters into the pancreas and causes insulin release? Can you tell me what is the GLUT channel through which oral glucose enters into the pancreas and leads to insulin release? Yes, it is GLUT2. Yes, it is GLUT2. So fantastic. So GLUT2 is what is present in the pancreas. GLUT4 is what we find in the in the muscles and the adipose tissue. So it is in these conditions that whenever these two channels, the GLUT4 channels, I mean, are not working properly, because they are not able to sensitize themselves to the insulin. What do you understand by insulin sensitivity? It's a common question that people ask. How many of you have used a remote at your home for your TV? Anyone? Abhi to you have finger touch TV as well. I'm talking of the days that I still have a remote TV in my home. How many of you have remotes for controlling TV? In the chat box, everyone. How many of you have used a TV with a remote where you press the remote? Yes, yes, I'm getting answers, Dr. Twinkle. Yes. So have you undergone that pathetic situation when you want to switch on to your favorite channel and you're pressing that button of the remote, but somehow the TV is not opening? I mean, the TV is not leading you to that channel. So what you do is you check the battery, you remove the battery. If the battery is, I mean, you replace the battery. If the battery is also, if after replacing the battery as well, there's no change, you strike the remote, on the back of your hand. You think that if we beat it, we'll probably start getting a better signal. How many of you do it, including me? I've also slapped the remote probably 100 times. Yeah, fantastic. So that's exactly what I mean by insulin resistance. So here the remote is supposed to have a transmitter and the TV is supposed to have a receiver. And whenever I'm pressing that certain key of the remote, they are supposed to have an interaction by which a digital analog signal is supposed to be converted and the TV is supposed to work. But what if the remote is fine, the TV is fine, but there's some problem in the transmission of signals? So it is in this condition that the the TV will be thinking that the remote is not working. The remote will be thinking, I am working, the TV is not working. So it's exactly such conditions where the GLUT4 channels are defective and insulin uptake into cells is relatively lowered. So we say that the cells have become insulin resistant or insulin sensitivity of the cells have reduced. So this is exactly what happens in type 2 diabetes mellitus. So I am repeating something that unlike type 1 diabetes mellitus, where there is global beta cell destruction due to autoantibodies, type 2 comes with a case where insulin is present, beta cell mass is usually okay, normal, but due to increased insulin resistance, due to decreased insulin sensitivity, whatever you call, with time, the beta cells start getting overwhelmed, and that is exactly when it starts undergoing destruction. When there's a low mass of beta cells, that is what leads to a relative insulin deficiency. Please note, when I talked about type 1 diabetes, I talked of an absolute insulin deficiency. In type 2, there's a relative insulin deficiency which is occurring, and that is what is leading to the symptoms of diabetes mellitus. And because insulin is present, I mean, in type 2 diabetes, you are having some insulin. Although the insulin is not able to work through its full potential, you're having some amount of insulin, which is why you will never find ketosis. How many of you know this, that insulin is the absolute deficiency of insulin is what leads to ketone bodies? How many of you know this? Yes, I'm going to repeat again. Yes, Mohammed Umar, I'm going to repeat again. What I said is, because in type 2 diabetes, the insulin is present, but it is not able to work. I mean, the situation where the remote is present, but it is not able to work. The TV is not working, although the remote is working fine. So it's a case of remote resistance or insulin resistance. So it is exactly in this situation, because insulin is present, it can never lead to ketosis, because even a small amount of insulin, if it is present in the blood, you can never have ketosis. How many of you know this, that if there is insulin, you can never have ketosis? How many of you know this? How many of you know this, that insulin, if insulin is present even, yes, if insulin is present even in a small amount, it can never lead to ketosis. Everyone agrees with me on this? अगर थोड़ा सा भी इंसुलिन है तो कीटोसिस नहीं हो सकता है. Why? Because ketones are what we produce in a state of starvation, right? Insulin is an anabolic hormone. Insulin is what gets released when we are in a fed state, right? Am I right? Insulin is what releases in a fed state. Ketosis is something which is a starvation induced metabolism of the body. So in type 1 diabetes, because there is no insulin, the body perceives that I am always starved. I am always in a state of starving, which is why you will always find type 1 diabetes patients are usually very lean and thin. Have you noticed this? Type 1 diabetics usually very lean and thin. I'm not saying every type 1 diabetic is lean, but mostly the type 1 diabetes mellitus patients are usually very lean and thin. Yes, whereas a type 2 diabetes mellitus, on the other hand, will always want to eat. He'll say, I'm hungry, mujhe khana hai, right? So yes, so this is because if insulin is present even in a small amount, the body will always know that it's in a fed state. So it can never produce ketone bodies. So DKA is something that can never happen with type 2 diabetes, which again affirms my point, which I said in the beginning, that if a patient is coming to you with DKA, it cannot be a type 2 diabetic patient. It has to be a type 1 diabetic patient. Am I right? Yeah. Everyone's clear with it? Perfect. Yeah. Now let's move to MODY. Okay. MODY and LADA, new terms. Maturity onset diabetes of the young. MODY is very much like type 1 diabetes. But let's be honest, it does not involve autoantibodies. Yani ki there is a beta cell dysfunction, but there is no autoantibody mediated destruction. It is mainly found that it is a cytokine mediated beta cell destruction, which is occurring due to a misalignment of the T regulatory cells. So that is what is leading to beta cell destruction due to the cytokines that are produced, but it is not autoimmune. And that is why, due to beta cell destruction, and it's a gradual destruction, mind it, it's a very gradual destruction, which is why insulin usually stays normal. And because it is not autoimmune, we do not find autoantibodies. But one classic thing of MODY that separates it from the other types is a very, very rich family history. It says you can never diagnose MODY if there is no family history over the last 3 generations. So at least 3 or more generations having MODY is what is what will lead you to the diagnosis of MODY. So this is one particular type of diabetes which has a very rich family history. Type 1 does not usually have a family history. Type 2 is plus minus. You may get, you may not get, but MODY is something which will definitely have a family history, and usually these patients will be less than 25 years. As I said, these patients are going to be very young, and the beta cell mass is going to be normal initially, but gradually there'll be a beta cell dysfunction. There'll be a beta cell dysfunction gradually. Okay, now the phenotype of these patients, as I said, they may require insulin, they may not require insulin, so that is typically variable. MODY is very common in, oh, no. It is MODS, my dear. Dr. Twinkle, what you are thinking as acute pancreatitis and that is MODS, that is multi-organ dysfunction syndrome. You have completely misjudged both the topics together, Dr. Twinkle. It's perfectly okay. My dear, that is multi-organ dysfunction syndrome, where due to acute pancreatitis and sepsis, there is a massive cytokine release that is going to lead to pneumonias, that is going to lead to sepsis, that is going to lead to renal shutdown, and gradually going to lead to multi-organ dysfunction syndrome. It is not MODY, it is MODS. Okay, everyone's clear with MODY? Now let's move to LADA. LADA is latent autoimmune diabetes of the adult. So as I said, a type of type 1 is MODY, but a type of type 2 rather is something which is what I call as LADA. So LADA is autoimmune. It is a type 2 autoimmune. Basically, if type 2 became autoimmune, what would happen is what we call as LADA. Here, the insulin is maybe present, maybe absent. Autoantibodies are definitely positive. Family history is very rare because, as I said, MODY is the only one which has got a very rich family history. These patients will be usually adults with beta cell mass ranging from 50 to 75% of the original activity. Decay will be very rare at presentation. And these patients, they have a very classical thing. So initially, yeah, I'll be explaining MODY again. Let me just finish off with LADA. So what happens in LADA and why exactly? Somebody said it's type 1.5 diabetes mellitus. Yes, it is type 1.5. It is because, so a patient who, so this guy will come to you, it's a 35, 40-year-old guy comes to you and with classical symptoms of diabetes mellitus. Your lab investigations will say diabetes, and you will start this patient on oral hypoglycemic drugs, mainly sulfonylureas. That's what we start with. I mean, anyone knows sulfonylureas? Are you all aware about the pharmacotherapy of diabetes? Sulfonylureas like glipizide, glibenclamide, all of that. Yes. So fantastic. Yeah. Thank you. So this patient will be given sulfonylureas initially, and this patient will be responding pretty good. After 6 to 8 months, gradually you will find worsening of diabetes. The diabetic control is absolutely going haywire. HbA1c is getting off the roof. And you'll be surprised. I mean, when you ask this patient, have you changed anything? Are you taking your medicines on time? This patient is like, yes, doctor, I'm perfectly doing all the things that you said. I do not know why, but I have not been feeling well. I've been gaining weight and I have not been doing well. My HbA1c report, when we started off with the sulfonylurea, was so good. I was in good control. Suddenly, I am not able to manage. You will start switching between the OHAs, different options, but you will not be able to control his diabetes. This is exactly the time when you will be forced to go into insulin, because this patient's HbA1c will be more than 8, more than 9, and you have to go to insulin because a patient who is resistant to OHAs and having a poor control of diabetes, you have to shift to insulin. The moment you shift to insulin, this patient starts showing remarkable improvement. Remarkable improvement. So this is exactly a case where a patient who was initially non-insulin dependent was well managed with oral hypoglycemic agents. Over a period of 6 to 8 months or 1 year, starts becoming very, very insulin dependent and starts developing symptoms of insulin dependence. So this is typically LADA. So for someone who did not understand MODI is typically a case where, due to the plasma cell defects, or due to certain T cell defects or cytokine defects, there is going to be a particularly a type where the beta cell mass will be usually preserved, but the insulin release, the per se the insulin release will be something which will be normal, the beta cell mass will be normal, but you will be finding types, signs and symptoms of diabetes, clinical symptoms of diabetes, and lab findings of diabetes because of certain, problems in the regulatory genes of the immune system due to beta cell dysfunction. Due to B cell dysfunction or due to T regulatory cell dysfunctions, it is usually found that these patients will be, suffering from a lack of insulin activity. The insulin that is produced usually is in a good amount, but this insulin is what we call as a useless insulin. It's not able to function properly. It is in these conditions that we call it MODI, and MODI does come with a very high family history. At least 3 generations will be involved. Most of these patients may require insulin or OHAs, or at times, both, a combination of both, as and when required for managing their glycemic controls. And anything like DK is very rare, but these patients will come to you very young. They'll be, less than 25 years of age, and there'll be an immune dysregulation which will lead to MODI. I can just show you something. Let me just try seeing if I can show something to you, which just give me a moment. Everyone ready to hold for 10 seconds so that I can find out something for you? Everyone in the chat, 10 seconds of patience. Just give me a moment. Yes. So I have something for you. People who were asking me about how and what happens in MODI.
Doctor, sorry to interrupt, but the screen is not sharing.
Yeah. I know. I have
Okay.
I've deliberately switched it off. So
Okay, done. Sorry to interrupt. Sorry to interrupt.
Perfect. No issues. Yeah. So I'll be sharing my screen, and this should help you to understand MODI. So can every one of you see this slide? Can you see certain genes, HNF4 alpha, HNF1 alpha, PAX4? Everyone? Yes, fantastic. So do you realize that whenever insulin is a protein, right? So whenever a protein has to be synthesized, first we undergo replication, and then we undergo transcription, and then we undergo translation. And translation is what leads to protein synthesis. Everyone agrees to this? Basic biochemistry, replication, transcription, translation, and then proteins. So whenever translation occurs, it's not directly that after translation proteins will be synthesized. There are a lot of post-translational modifications that occur. And it is in this type of post-translational modifications that certain genes or certain transcription factors or translational factors, which was supposed to make that protein molecule, is defective. So insulin is produced, but the insulin that is produced is not of a good quality. The peptide chain is produced, the protein is produced, but it is basically a protein which is not able to function properly. So this basically, MODI is a type where is a functional or a qualitative deficiency of insulin. It's not a quantitative. See, whenever I talk of type 1 diabetes, this absolute beta cell dysfunction, there is a quantitative deficiency of insulin, right? Whenever I talk of sound is not clear. Are you not able to hear me? Vijay, am I audible?
Doctor, you are audible. You are audible.
Yeah. Okay. Somebody said sound is not clear. Yeah. Okay. Yeah. Clear. Thank you. Thank you so much. So you can, somebody who's facing issues can just log out and log in again. I think that'll be perfect. So yes, as I was saying, because of this, the qualitative deficiency of insulin, it is not able to exert its actions. That is why when you look at the table that I shared, you'll be classically finding that the beta cell mass is absolutely fine. You'll find that the insulin levels are perfectly fine. But what happens is these patients will be having still a relative deficiency of insulin function because it is a qualitative deficiency of insulin. It's not a quantitative deficiency. Okay, is this clear? Yes, perfect. So before I go into insulin, I wanted to actually take you in a reverse way. I mean, everyone is more about talking about insulin first and then OHs. I thought let's do it in a reverse way. Let's first do the OHs. Okay? Let's first do the oral hypoglycemic agents so that we have a brief idea and a crisp idea of what to give to which patient, when to give, and how to give. I think that is what is very important. I'll be not talking of the regimes because that, as I say, see, I always say this. There are so many times, I find my juniors asking me, what is the drug to be given in hypertension? What is the drug to be given in diabetes? There is no hard and fast rule that you need to give this drug to this patient. Basically, it's a customized thing. Just like when you go to a restaurant, you customize your dish. Basically, any treatment of diabetes or hypertension or CKD for that matter is a customized treatment. You need to understand what suits the patient best, what is helping the patient stay in good control, and if it is not, you just need to change it or alter it. What I mean by it is what may work for one patient may not work for the other patient. So that is something that we that we need to understand. Yeah. Okay. So coming to type 2 diabetes mellitus drugs, the oral hypoglycemics predominantly, I mean, we have quite a number of drugs, and I'm very sure every one of you are aware of the types of drugs. You're aware of sulfonylureas, you are aware of the DPP4 inhibitors, you're aware of the GLP-1 receptor agonists. Everyone is aware of that. I don't think I need to go into the basics of that. Anyone who does not know what a GLP-1 agonist is, what a DPP4 inhibitor is, what a SGLT2 inhibitor is, because everyone, the one who was the junior most, I think, was in an internship year. So I would presume that you know it, which will actually make this discussion more crisp and much more interesting. Okay, so when I say the most common doubts that a patient who is receiving oral hypoglycemic agent therapy comes and says, doctor, what is the risk of hypoglycemia? What if there's a risk of weight gain or weight loss? What is the risk of major cardiac events? So what I've tried to do in this table is sum up all the drugs that can lead to certain complications. So whenever a certain patient comes to you, you will customize the drug choice according to it. You will know that, okay, if this patient is a cardiac patient, along with, he has some cardiac abnormalities or a cardiac condition, along with the diabetes mellitus, I will know what are the drugs of diabetes that I can give to reduce his cardiac mortality or to increase his, quality of life or to reduce the in-hospitalization cases of cardiac mortality. If a patient of CKD is coming to you, if you know what is the drug that will prevent edema, what is the type of drug that will also control diabetes and also, prevent the diabetic nephropathy from progressing, you'll be able to customize the drug according to that. So that is entirely my way of approaching this topic. So when I talk of hypoglycemia, a very common question that people ask is, I'm having medicines which for diabetes, what if I become hypoglycemic? So mainly only one class of anti-diabetic drugs, which is oral, can lead to hypoglycemia, and that is what we call as the insulin secretagogues, what is also called as sulfonylureas. And in sulfonylureas, we only have the long, because sulfonylureas are usually long-acting, usme bhi what we call as the meglitinides, I mean, the meglitinides and the sulfonylureas, which are long-acting, are the ones which are going to cause a risk of hypoglycemia. And what we usually advise to these patients, see, I personally am a very big against in giving sulfonylureas. I personally don't give this to my patients. I don't like giving it to my patients personally because not just because of hypoglycemia, there are a lot of complications. These patients don't tolerate sulfonylureas very well, and the major complications that happens with this patient is one attack of hypoglycemia and they will land up in the emergency. I always say this: hyperglycemia will never kill you unless it is a ketotic state or a hyperosmolar coma. But hypoglycemia, even one episode of hypoglycemia is enough to kill you. Everyone agrees with me? Everyone agrees with me. Hyperglycemia will usually not kill you acutely. Acutely, it will not kill you. But one episode of hypoglycemia is enough to kill you. Correct. So what I've seen over time is when you give sulfonylureas to a patient, and even if they have developed one attack of hypoglycemia and they land up in the emergency, trust me on what I'm saying, they'll change the doctor. They will not come back to you again. And very rightly so, because they are so scared of a hypoglycemic episode, because it comes with palpitations, blood vision, there's a chest discomfort, the hands are shaking, there's tremors. And anyone, I always say there are three things which a person remembers all his life: the pain of an MI, the pain of a renal colic, and a hypoglycemic episode. Everyone agrees? The pain of an MI, hypoglycemic episode, and a renal colic. These three conditions, everyone remembers in their life, and they are traumatized by it. Ask me, I've gone through a renal colic, thankfully not gone through an MI and a hypoglycemia, but I can tell you, these three things, patient will obviously remember. And if you are the doctor and you have given a sulfonylurea, this patient has landed up in the emergency with even one hypoglycemic episode, take my word, darling, you are not the doctor that this patient is going to see again. Because not just that, this patient most likely will not even visit any other doctor. And believe it or not, 2-3 days back, I met a patient. I'm definitely not going to name her. She's having an HbA1c of 8. Believe it, 8. She's a mother of a little girl. She is having a high BMI. She's having an HbA1c of 8. And she told me that I am not using anti-diabetic drugs. Why? Because she was given sulfonylureas. And 2024, she landed up in the emergency with a hypoglycemic episode, was admitted for almost 1 to 2 days. And you can understand, she did not have an insurance, there's in-hospitalization cost and everything. She was so fed up that she did not visit a diabetologist any time else after that. She's still without any therapy of diabetes. She's having a HbA1c of 8. Do you realize how difficult it is to convince this patient that you need to see me again? I mean, if this was happening to you, you would definitely not have gone back to the same doctor again. Agree it or not? If this was happening to you, even as a medico, you would not have gone back to the same doctor, because hypoglycemia, even one episode is enough to kill you. See, everyone agrees? Okay. Now, so these are drugs which I usually don't prefer, sulfonylureas. And it is because of the same reason that, insulin secretagogues like sulfonylureas, they also lead to increase in weight. They also lead to increase in weight. Can somebody tell me why does sulfonylureas lead to increase in weight? This is a chocolate question. This is a chocolate question. A patient has been given sulfonylureas, and this patient comes to you and is showing increase in weight. Can anyone tell me why insulin secretagogues like sulfonylureas lead to weight gain? Okay, due to insulin secretion. Due to insulin secretion. I know this would have been the answer, because that is why I asked. Okay, somebody wrote calories retained. Okay. Fat storage, Twinkle? No, not really. Not really. I'm still wanting to hear from Dr. Aftab Aga, who says calories retained. You are somewhere close to the answer. Yes, somebody has finally given me the right answer. It is Dr. Ilya Raja. Wow, you have a name of a very famous music director from Kerala. So Dr. Ilya Raja, it is high food intake, and also Dr. Aftab Aga says increased appetite. Perfect. So the usual answer which I've found people giving is Dr. Aftab and Dr. Ilya Raja. What are you doing currently? Are you pursuing your residency, or you are in your MBBS? I really want to appreciate both of you. Yes, increased hunger, Dr. Bhagyesh. Doing PG, Dr. Aftab, very good. I'm so glad. I'm so glad to hear this, because most of the times we feel that insulin secretagogues, because insulin is an anabolic hormone, it will lead to weight gain. No, it is not. That is not the reason why these patients come to you with weight gain. So, do you realize that I said that these drugs are very long acting and they have a risk of developing hypoglycemia, right? Whenever this patient develops symptoms of hypoglycemia, the brain automatically, the hunger center in the brain will automatically get stimulated and tell this patient, khao. That is what we call as stress snacking. Stress snacking. Dr. Aftab, am I clear? There is stress snacking. Whenever there is stress snacking, what happens is this patient will eat more. And I'm so sick and tired of clinicians, with due respect to everyone, who will say these patients, you are not controlling your health well. this patient is on sulfonylurea, and this patient is made to hear, you should suppress your hunger, you should not be eating. The hunger that is happening in this patient is a life-saving hunger, because this patient is undergoing frequent dizzy episodes, frequent hypoglycemic episodes. You cannot expect this patient to not eat, because this eating is what is keeping him alive. So this is exactly why insulin secretagogues like sulfonylureas will lead to weight gain. It is not because of the anabolic action of insulin, but it is due to the hypoglycemia induced stress snacking, which the patient does. And every time you eat more, in intervals, if you keep eating, what happens is you start gaining weight. So that is what Aftab meant by retained calories, and many other people like Dr. Bhagyesh and I think Dr. Ilya Raja. Fantastic. I'm really glad, really, really glad. Okay. And there's another drug which can cause weight gain, that is pioglitazone. Anyone who knows why pioglitazone can cause weight gain? Anyone? Anyone who knows why pioglitazone can cause weight gain? I'm asking you, suppose, I'm asking you, so this is my father, okay. My father is 62 right now, with a weight of around 84, 85 kgs, for example. He is obese, and he has been given pioglitazone. Should I stop pioglitazone in him? Should I stop pioglitazone in him? No, it is not. It is not edema. It is the water weight. Yes, it is the water weight. Somebody wrote water retention. Yes, it is water retention. And mind it, usually this water retention will not lead to heart failure. What we usually say, that fluid retention and water retention can lead to heart failure. Usually these patients will not have a risk of heart failure. However, these patients who already have a low cardiac reserve, patients who are already having some low ejection fraction, if these patients are given pioglitazone, these patients can develop frank symptoms of heart failure and heart failure hospitalizations. That is perfectly true. So what the weight gain that is found in pioglitazone is mainly a water-based weight gain. The drugs which reduce weight and are fantastic drugs, these are the drugs which I usually prefer. They are the GLP-1 receptor agonists and the SGLT2 inhibitors. So these are the two classical types of drugs which will reduce weight. When I talk of MACE is major adverse cardiac events. Rosiglitazone is what has been shown to increase the risk of MI, and popularly we say this ki Rosie dil le gayi. So Rosie is the name of the girl, and she's broken your heart. So rosiglitazone is what is associated more with MI. And GLP-1 receptor agonists like liraglutide, like dulaglutide, like semaglutide, and SGLT2 inhibitors like canagliflozin and empagliflozin have been shown to reduce the cardiac events. So anti-diabetic drugs which have got added cardiac benefit, cardiac mortality benefits, they're obviously the glutides and the gliflozins. And especially among gliflozins, it is the canagliflozin and the empagliflozin. Heart failure hospitalization, as I said, pioglitazone can lead to heart failure hospitalization in patients with a low cardiac reserve. Apart from that, alogliptin and saxagliptin have also been shown. However, the SGLT2 inhibitors, mainly the DAPA and the EMPA, the dapagliflozin and the empagliflozin, have been shown to reduce the heart failure hospitalizations. So you can see clearly that SGLT2 inhibitors overall, apart from being anti-diabetic drugs, they have a very, very, very good cardiac profile. Drugs which reduce the progression to diabetic kidney disease, they are SGLT2 inhibitors again. All SGLT2 inhibitors, DAPA, EMPA, CANA, all of that will lead to a decrease in the progression of diabetic nephropathy. And GLP-1 receptor agonists like liraglutide, dulaglutide, and semaglutide. So yes, that is what will also improve the diabetic renal profile. They are good renoprotective drugs. They reduce the progression to nephropathy. Okay, anyone who knows what is teduglutide? Why have I not mentioned teduglutide as anti-diabetic drugs? Anyone who's aware of teduglutide? TEDUGLUTIDE. Anyone who knows what teduglutide is? It is also a glutide, but why have I not mentioned it as an anti-diabetic drug? Yeah, DAPA EMPA can cause UTI. Yes, I will go there. I'll go there. DAPA EMPA very commonly does cause UTI. Yes. So we need to be very careful about that. Yes, but what is teduglutide? No, teduglutide is not used for weight reduction. No, it is not used for weight reduction. In fact, teduglutide has the word tedu, do for two. So it is a GLP-2 receptor agonist, and it is used in the treatment of short bowel syndrome. It is used in the treatment of short bowel syndrome. Okay, everyone's clear with teduglutide? It is, although it is a glutide, it is not a GLP-1 receptor agonist. It is not a anti-diabetic drug. Am I clear? Everyone's clear with this? Sure. Sure. Okay, fantastic. So teduglutide is GLP-2 receptor agonist. Now, diabetic drugs which are used in CKD, because in CKD there's a problem. What is the problem with CKD? See, insulin usually has a renal route of excretion. So insulin cannot be given with the same dose in a chronic kidney disease patient. DAPA and EMPA, yes, somebody saying DAPA and EMPA is the medicine of choice for CKD. Yes, DAPA and EMPA is a very good drug for patients of diabetic nephropathy, but yes, it does come with certain factors like, they have a high risk of causing urinary tract infections. So we need to be really careful when we're giving it to elderly females. I have a couple of patients of mine who are elderly females, and they have not been able to tolerate dapagliflozin or empagliflozin for that matter, because they have been developing frequent UTIs and vulvovaginitis following that. So yes, but they are very good drugs when it comes to renal protection. They are really very good drugs, and mainly these patients also are hypertensive. So if you combine it with an ACE inhibitor or an ARB, it is a fantastic combination. Trust me. So as I said, insulin is something which is excreted by the renal route, and in patients of chronic kidney disease, these patients will usually need dose adjustments of insulin. So we have certain drugs which are contraindicated in chronic kidney disease, some drugs which are safe, and some drugs which we can use with dose adjustment. So the one contraindication, a drug which you can never ever use for a patient of chronic kidney disease, is metformin. Anytime the eGFR is less than 30, or the serum creatinine is more than 1.5 in a male or 1.4 for a female, you can never be using metformin. Please avoid metformin. The drugs which you can use with dose adjustment, the drugs are insulin. The drugs are DPP-4 inhibitors like the vildagliptin and the sitagliptin. Yes. DAPA can be used. Yeah, DAPA can be used. DAPA can be used. More than 50 it can be used. Yes. And sulfonylureas, the drugs which are used as drugs which can be used in a patient of CKD with dose adjustment. The sulfonylureas include glipizide and gliclazide because they are adeno safe. But trust me, gliclazide, glibenclamide, ya fir glimepiride, these are poor drugs. These are not really safe for the kidneys. So it's better to, if you're at all going with a sulfonylurea, it's better that you go with a glimepiride. I mean, better you go with a glipizide or a gliclazide, for that matter. And drugs which you can use easily without dose adjustment. As I said, DPP inhibitors, all the DPP-4 inhibitors, we need dose adjustment except for linagliptin, LINAGLI. PTIN. Linagliptin has LI for liver, which means it is excreted by the liver. So it is safely considered for use in a patient with CKD. Pioglitazone can be used, but it is avoided because it can lead to edema. And in CKD patients, we are already running a risk of edema and heart failure. And GLP-1 receptor agonists can be used except exenatide and lixiseide. So except for these two drugs, we can usually safely use the GLP-1 receptor agonists. So yes, you can always use these patients. Linagliptin, as I said, is a very good drug for CKD. It is a DPP-4 inhibitor, but it is metabolized by the liver, so there's no chance that it would interfere with the renal excretion. Coming to the next part, that is the other side effects of certain drugs. So the GI side effects is very common with metformin, and the most common GI side effect that we come across is an unexplained watery diarrhea. The alpha glucosidase inhibitors like voglibose, which are absolutely. How many of you still have seen voglibose being given as an anti-diabetic drug? Still now, how many of you have seen voglibose? Clinicians prescribing voglibose. Okay. I can tell you something. Only if you promise me that you're not going to record this segment and not going to post this to the clinician outside. So if you promise me, I'm going to say this out. Okay. So the point is, India is the leading country where all the useless drugs and banned drugs, all the drugs which are banned and useless, which are not at all approved by the FDA, India is the only country which has a high sale of these drugs. None of these drugs have been shown to have any efficacy. And in fact, let me tell you, acarbose, voglibose have been banned by the FDA. They are not even FDA approved drugs. You can go to Google, you can search if FDA approves acarbose and voglibose. They are not used at all. But in India, somehow they gain a huge popularity. How many of you know this drug called magnet sport? How many of you know this drug called magnet sport? Cefoperazone sulbactam, which is given to patients of pneumonia in the ICU. They say that it has ESBL coverage. Yes. Can you please search the internet, any website, connect me, on my email or anything. Let me know if magnet sport cefoperazone sulbactam is an FDA approved drug. It is not approved by FDA. Any time you go to ask them, they will only say this, that no, certain results of trials in China have shown they have worked. They will only give you Chinese trials because no other country in the world has even accepted these medicines. And let me tell you a fun fact. Cefoperazone sulbactam, I mean, the company which produces it, I'm not going to name the company which produces it, they were themselves shocked that a drug which was considered as a, they were literally thrown out by the US, is something that gained so much of popularity in India. And why I'm saying, I'm not against any clinician. See, I'm not against any clinician prescribing a drug, but I'll be very honest. Maximum of Indian markets are having drugs which have absolutely no efficacy. How many of you have heard the name of the drug called Pharopenem? Yes. How many of you have come across this drug called Pharopenem, which is an oral form of meropenem? That's what they say. Brother of meropenem is Pharopenem. How many of you have seen surgeons giving it for infections, wound infections? Yeah, orally. Please go and check what is the bioavailability of Pharopenem. You'll find it is questionable. Nobody knows after you give a Pharopenem whether this drug is going to work, whether it is really bioavailable or not. And again, go and check it whether it's FDA approved. It is not FDA approved. It is not FDA approved. So the fun fact is, I'm not wanting to drift out of the topic much, but the fact is, India is the largest seller of dumped medicines and medicines which are absolutely banned in other countries. India will always promote it. Okay, I'm not even going into boost is the secret of our energy, and I'm not even going into other products which I will try avoiding. But yes, if you actually see the history of most of the things that you consume, even the baby foods that babies are consuming, you'll be shocked to understand that these have been banned by other countries because they have been shown to have no efficacy, or they have been shown to be toxic for human consumption. So coming back, alpha glucosidase inhibitor. Why production? Oh my God, this will lead to a different thing. See, the pharma industry in this country is nothing short of a mafia business. Let's not go into this, because the more we go into this, there'll be issues. What I can only tell you is, yes, it is commonly used by doctors. Yes, voglibose is commonly used by doctors, but I can clearly tell you it is not an FDA approved drug. I can use anything, but it is not an FDA approved drug. It only happens in India because the patient is not wise enough to come and ask to the doctor that the fact that you are giving me this, please show me data which has shown efficacy of these drugs. If the same thing was done in the US, trust me, anyone who has practiced outside India, the patient will come and ask you, please show me a trial which has shown me the efficacy of something like voglibose, which has shown me the efficacy of something like a cefoperazone sulbactam. And they even claim it that it has ESBL coverage. It has nothing. It has absolutely nothing. It is one of the worst drugs to give. Anyway, coming back, we don't want to go with this pharma business and everything. It's a total crap. The lesser we talk about it, the better, because we are doctors. We are supposed to stick to what we need to give, and what we need to practice. As a patient, I believe, because I have been a patient at some point of time. There are so many times when I assume the role of a patient. It is my duty to know what I'm being given. And when I sit on the other chair being a clinician, my only target is to make sure that I convince the patient about what I'm giving and why I'm giving. And I will definitely not give something which is not approved in literature, because there's a reason why researches are happening. Okay, coming back. Incretins like DPP4 inhibitors and these have been shown to have side effects of GI as well. Incretins classically can lead to pancreatitis, and certain OHAs which can cause cancers. If I talk of that, bladder cancer, pioglitazone is contraindicated in patients who are having a family history of bladder cancer. There's a very common misconception that pioglitazone causes bladder cancer. I don't know why. Probably because that is what we have been taught in our pharma days. But no, pioglitazone does not cause bladder cancer. There are so many patients. Pioglitazone had bladder cancer. None of the patients would be taking pioglitazone. In India, left and right patients are taking pioglitazone. Pioglitazone does not cause bladder cancer, but in a patient who has already had a family history of bladder cancer, pioglitazone is contraindicated. So it comes with a black box warning that if your family history is there of a patient having bladder cancer, please avoid it. Patients who are having, medullary thyroid carcinomas or pancreatic neuroendocrine tumors, GLP-1 receptor agonists should be avoided. They should be contraindicated in family history of MTC, of pancreatic carcinoma, and patients who are having MEN syndrome, because we know MEN2A is all about pancreatic neuroendocrine tumors and medullary thyroid carcinoma. Pioglitazone has been shown to cause osteoporosis. And another drug which earlier was said that it does increase the risk of fractures and amputation, but now the recent trials are increasingly saying that no, it is not right. This does not increase the risk of fractures. It is canagliflozin. Remember, it's not all the SGLT2 inhibitors, but it's just canagliflozin. Among ophthalmic manifestations, we have pioglitazone again, because pioglitazone, as I said, can lead to water retention. So it can lead to macular edema. And one drug which can cause worsening of retinopathy, it is semaglutide. Now, the moment I say it, I find people scared, because there are so many patients who are using semaglutide. And the one thing they'll come and say, oh my God, does this mean I'm going to get blind? No, you will not get blind. If a patient is not diagnosed yet with diabetic retinopathy, semaglutide is very, very safe. Only if you are diagnosed with diabetic retinopathy on fundoscopy examination will I not be able to give you semaglutide, because it can lead to worsening of retinopathy. One drug which improves retinopathy, on the other hand, is dulaglutide. It's dulaglutide. So that is all about retinopathy. And GLP-1 receptor agonists can cause, weight loss. As I said, some non-diabetic users benefits is SGLT2 inhibitors like DAPA and Pacana, which can lead to reduction in heart failure hospitalizations or reduction in major cardiac, events. And in cases of SGLT2 inhibitors, we say that, if it's a patient of CKD, you can continue to as low as EGFR of 20. You can continue with SGLT2 inhibitors. But if it gets below 20, you have to be careful in trying to withdraw these drugs. So late dumping syndrome is again caused by alpha glucosidase inhibitors like voglibose and carbose. But as I said, these are not even drugs which are FDA approved. Pharma books do cover it because it is indeed a pharmacotherapy, but it is not approved in the current practice. Coming to miscellaneous drugs, there are dual agonists, which is commonly by the GLP-1 receptor agonists or the GIP agonists, gastric inhibitory peptide. And this drug is what we call as the tirzepatide. And tirzepatide has been a life-changing therapy which has come up very recently, and it has been shown to give very, very good glycemic control. From a time when insulins were supposed to be taken daily, we now have weekly preparations of insulin. And the name comes with Icodec or Epsitora. These are the companies, or the brand names which are producing weekly insulins to produce good glycemic control, be it basal insulin control or prandial insulin controls. You have dopamine receptor agonists like bromocriptine, and you have bile acid sequestrants as well, which can be used as drugs to control the metabolism of diabetes. Anyone who knows the Indian version of a nasal insulin that was prepared? Anyone who knows the name of the nasal insulin preparation that was prepared in India? It's an indigenous product. Anyone knows the name of that preparation? It's a nasal form of insulin, intranasal insulin. Anyone knows that? Yes. Dr. Nazia, Dr. Balaji. Yes, it is Afreeza. Again, Afreeza came up with a lot of hype, but it is not proven to be any beneficial. There's not any evidence which says that Afreeza has better events or better glycemic control than any of the other drugs which are existing. In fact, it has a worse control than other insulins. So Afreeza is an Indian product, which is why I asked you about this. So once we are done with the type 2 diabetes mellitus, I don't know why. Just give me a moment. Yes. So yes, once we are done with the oral hypoglycemic drugs, we'll quickly switch on to insulin. And there's a reason why I've kept the slide of insulin very short. It's because insulin, the more we go into insulin, we have to talk about its regimens. And I don't want to talk about the regimens of insulin here because it will be very overwhelming for a few people. So I've tried to keep it very restricted to the pharmacotherapy part, wherein we have, initially when Banting and Best prepared the insulin, it was porcine insulin. It was made from pig. And then gradually it was converted into human insulin via, via the different layers of recombinant DNA technology. So today in the world, we are having insulin preparations, which are human insulin preparations. And insulin is something which is a lifesaver. As I said, it is a lifesaver, especially for a patient of type 1 diabetes. There's nothing better than insulin. So because of depending on the onset of action, whether it's very rapidly acting, rapid acting, intermediate acting, or long acting, we have certain formulations. But before I go there, which is very theoretical, can anyone tell me why does insulin take time to dissolve into the tissues? I mean, from the tissues to the blood. Usually you inject insulin via the subcutaneous route, right? Why does insulin take time to move from the tissues into the blood? Can you tell me anything about the absorption of insulin? Anyone who knows anything about the absorption of insulin? What happens after you inject insulin subcutaneously? Yes, it is in hexamer form. Yes, perfect, Dr. Balaji, it's in hexamer form. After that, it dissociates to form monomers, and these monomers are what gradually, moves into the blood and starts getting absorbed. So that is exactly what happens in a case of of uh, insulin administration, which is via the subcutaneous route. So yeah, that is, and depending on this property of regular insulin, we have certain other things which we mix it with so that the absorption is faster. Either what we can do is we can mix it with compounds like zinc, which we can mix with compounds like protamine. All of that will delay the crystallization of the hexamer into monomer forms. So what happens is the hexamer into monomer, and then the monomers getting absorbed through the bloodstream takes time when we combine it with zinc, when we combine it with protamine. However, there are some very rapidly acting forms like lispro, like aspart or glulisin. When they don't stay as a hexamer, I mean, the moment we take it in the vial where we are trying to inject, these hexamers will quickly or rapidly, they'll dissociate and form monomers. And these monomers are what are gradually taken up into the bloodstream, right? So in cases of rapid acting insulins, we have a short onset of action, like 5 to 15 minutes. So basically, it's so cool for the patient that, once you sit for your meal, be it a lunch or dinner, you can quickly get a shot just 5 or 10 minutes before you take your meal. Or at times, if you have even forgotten to take a shot, you can take it right with the meal that you're taking, because it's so fast acting. It is very useful in people who are elderly and forget to take their doses, or in children where you cannot, I mean, suppose you're using a regular insulin, you should wait at least 30 minutes after you inject insulin for yourself to take a meal, which is almost impossible with kids. I mean, you cannot tell a 15-year-old kid that you take an insulin shot and then wait for 30 minutes before you take your meal. That usually does not happen. Also, this can lead to a lot of problems in compatibility with using these insulin formulations, which is exactly why the rapid action forms like lispro, aspart, or glulisin have come in the market, and they have a very rapid onset of action. What happens is you can take it with the meal, you can take it 5-10 minutes just before the meal, and they'll peak between 45 to 75 minutes. Within the next 1.5 hours, they'll peak as well. And because they have a very sharp peak and they have a very sharp fall, the risk of hypoglycemia is very rare with the rapid formations. They have a very sharp peak and a very sharp fall. You can see it in the graph as well. In this graph, you can very clearly see that the rapid action insulins, they have a very sharp rise and they have a very sharp fall. Compare it with the short or regular insulins, you'll find that the peak is gradually, it's very gradual, it's slow, and the fall is equally very gradual, it's very slow. So yes, we have the intermediate insulins, which is called the NPH, where we are combining the regular insulins with protamine. And what happens when we combine it with protamine is that protamine stays in the blood for a longer while and does not allow the insulin molecules to dissociate into monomers. What happens with the long insulins like glargine or degludec or detamir is we are combining other compounds like zinc, we're combining it with regular insulin, or for especially like glargine is the only insulin that we have an acidic pH. Glargine is the only insulin that we have at a pH of 4. So at this, I'll answer your question, Dr. Mayur. I'll answer your question very soon. So glargine is one insulin which comes at a pH of 4. It is an acidic insulin, and what happens is because of this acidic pH, the insulin molecules, they stay in a crystal formation. Because they stay in a crystal formation, they do not usually dissociate to form monomers very easily, which makes it very long acting. And you can see the long acting ones like the detamir and the glargine, they usually are very peakless insulins. Although theoretically they are called peakless, but they do have a peak, but it's so negligible that for the practical purposes, we say that they are peakless insulin formulations. And here we talk about the different types of delivery. This is an insulin infusion pump. These are insulin pens which are very commonly used. And we also have something which is, anyone knows what is the name of this device? Anyone knows what is the name of this device? What is the name of this device? Anyone who's aware of what this device is? Yes, it is a CGM. Yes. The CGM means continuous glucose monitoring. It's a very handy device, and in fact, it's one of the most gold standard devices right now, where you don't need to multiple times. You don't need to prick this patient. It avoids multiple pricks. It's a device which will stay attached to your body, and with every meal that you have, it will have a sensor here, and with every meal that you have, it will show what is your basal level of insulin, and with every meal, what is the amount of rise that is happening postprandially. It's a fantastic device that helps you regulate your insulin doses as well. It helps you know what is the time of the day when you're having maximum glucose, what is the time of the day that you're having minimum glucose. So it also avoids hypoglycemic risk. And yes, it is really accurate. Yes, it is accurate. Yes, it is. It is very accurate. In fact, it is one of the gold standards. This is the CGM monitor that I've typically tried showing. You can see there's the basal level, and it is showing exactly the meal timings and the rise in the glucose pattern that you are having. What CGM does is it is as efficacious as an HbA1c in monitoring glucose control. HbA1c gives it over 3 months. CGM gives it on a daily basis. And you can also customize the data of CGM and find an average over the last 3 months. It is very, very good. This picture shows the common sites of administration of insulin. So the buttocks contain the maximum fat, so the least absorption occurs from there. Arms contain the least fat. It's a place from where you have good absorption. You can also have a very good absorption from the abdomen. But what is very important to know is you need to switch the sites alternatively every time. You don't need to keep on giving it in the same site because it increases the risk of something which is called lipodystrophy. Lipodystrophy is what I've shown here in this picture. So because of giving insulin continuously at the same site for weeks and months together, it can lead to something which is called lipodystrophy. And this is actually a case where there's a hypertrophy of the fat cells. And this is exactly what you can say due to the anabolic effect of insulin, the fat cells increase in that particular site and causing a local hypertrophy of the adipocytes. So that is all about insulin therapy. I've not gone into the deep aspects of insulin therapy. There's one question that I found from Dr. Mayur. Is there any complication of very rapid insulin? Are you meaning an insulin bolus? If you mean an insulin bolus, you are not supposed to give an insulin bolus, my dear. IV insulin is supposed to be given very slowly. It cannot be given, like a bolus dose. You cannot give a rapid push. Yes, you can give a bolus, but you cannot give a rapid push of IV insulin. And the only case where we give an IV insulin, IV regular insulin, is in case of BK. Intramuscular insulins, yes, apart from subcutaneous routes, we can also give by intramuscular routes. In fact, intramuscular routes have proven to be better. And one more thing, exercising. When we exercise and we take insulin in the same limb, suppose you have exercised with your biceps and you're taking insulin in the same arm, it will lead to increased insulin absorption. So that is something which we can consider. So in short, I've tried to explain all the components that are present in the pharmacotherapy. And what I've tried making sure is you have a comprehensive overview. We can always have a session later where we talk about how much insulin to give in what patient, and that will be very customizable. But yes, we can have a session on that, but that would again be a separate session that cannot be included in this session because it's going to be really long after that. So I've tried making it as crisp and concise as possible. Thank you all for attending the session, and it means a lot to me. I would want you to post your queries right now. Let me come to the original chat. Give me a moment. Yeah, I would want you to post me your queries and anything that you would wish to ask me. I'm more than happy to respond. Thank you. Thank you. It's been a fairly good audience of around 125 to 150 people, and I'm so glad. I'm so glad that you have been there. I've not been particularly doing well, but thank you so much for being there. Yes, I can share the PPT. I think the team will get through to you, Dr. Mayur. The team will get through to you, and will always be able to share. A part of this lecture, I mean, the lecture will be uploaded on YouTube. So anyone who is in the channel of Mediversal Academy, you can always access this lecture from YouTube, and you can always take down the PDF, and you can keep it for your future references as well. You can even add this into whatever presentations you make later, and just make sure that you are giving my name in it, because don't plagiarize it. Do give my name, but yes, I would love to have you adding to this and making this a better one. So yes, the certificate link and everything will be shared by the team, by the respective members of the team. Thank you to all the members of Mediversal as well. Everyone who has been directly and indirectly a part of this, and are always there for my webinars, be it Ifka, be it Srinivas sir, be it Vijay sir, and everyone else. Whether I take your names or not, just know that you all have a very, very special place in my heart. Thank you so much. Vijay sir, you can
Yeah,
uh,
thank
take
you,
this.
doctor. Thank you so much. Yeah, I just want to take one moment here, and somehow, whenever you are busy, no matter what, be it your health or be it your profession, you always make some time to come out here and educate our doctors. Thank you so much. It means a lot to us, and I, on behalf of all the doctors here, would really convey my gratitude to you, and thank you so much, Dr. Navanil. And doctors, thank you for attending the session. We are dropping certificate link. Please click on the link, fill the form, and to get your certificates. Also, I'll be dropping our social media channel links. You might already following us. If not, please do follow us on social media to stay updated on all our upcoming webinars. And yeah, please do follow us on social media channels. And
Discussing patient cases, and okay, so again, I'll just only say this: my contact details is something which the team will take care of, and I won't be able to particularly attend to personal things like this. But one thing which I can surely do is, as and when the team decides, we can have a common setup, maybe once in a few months. We can all gather together, and we can share on. We can just talk about the different cases that we get. So that can be possible, but then again, the team will get back to you for that.
sure, sure, sure. We are coming up with a platform to solve all these case discussion issues where you can come and drop your cases, and our mentors like Dr. Navonil will be able to answer your cases. We are very shortly launching something called portal where you all your queries can be addressed, and you also get an opportunity to talk to our mentors. Everything it is in the pipeline. Please allow us some time. We are building something really beautiful for the doctor community, because we are here to build community to touch most of the issues which is surprising the doctors today. Thank you. On that front, I want to end the session. Thank you, doctor. Thank you so much for the insightful
Thank you
session.
so much. Thank you
I
so much.
Yeah, I do tell this, but I really mean a lot. I personally learned a great deal today, and I'm sure doctors would agree with me. On behalf of everyone, I would love to extend our sincere gratitude to Dr. Navanil.
Thank you so
And
much.
yeah, and the kind and this kind of engagement with our participants will always motivate us to organize more such webinars in the future. Thank you all for joining us today. We hope you find this webinar informative and valuable. If you have any further queries, as you know, you have all your social media channels. You can feel free to reach out to us. We have dropped the certificate link. I would dropping it again to help you further. Please do fill the form to get your certificates. And due to a lot of webinars we are doing, this might get the certification dispatch might get delayed. Please wait. In next 2 working days, you will get the certificates. Thank you so much. And yeah, thank you. Thanks a lot. Thank you, doctor. Thank you so much for
Thank
joining
you so
today.
much. Thank you.
And being your health condition, you didn't even ask to postpone this. You always been supporting to this such sessions. Thank you so much.
Thank you so much. Take care, every one of you. Thank you. Good night. Yeah.
Good night all. Good night all.